The audience, would anyone like to volunteer? Anyone like to volunteer to run around with the mic? You can pretend you're on telly.
I'm a speaker, but I can help. It's fine. So when I speak, somebody else can do it, but I don't mind. Yeah, but maybe we can collaborate. Beautiful. No problem. Good. Nice to meet you.
So good morning, everybody. Thank you and welcome to the last day of the conference. We've still got a full agenda today. So I'd ask anyone to ask questions on the app if there's anything pressing that comes up as you're going along. And that's for people that are joining us live on the live stream. If you ask in the app, you can give it a thumbs up and we can prioritize these questions. Also, if you want to tweet about the session today, it's hashtag ICIC23. And we are here today talking about the healthy aging and integrated care for older people in this session. I'm going to bring up Alyssa now to come and talk about, bring her experience from Singapore about the built environment. Not you. We're just going to make a small change to the slides.
Okay. Hello. Good morning, everyone. Thank you so much for being here. So my name is Alyssa. I'm a final year medical student at Duke-NUS, which is a postgraduate medical school in Singapore. And it's really a privilege to be here, coming all the way from Singapore, being able to be exposed to a whole new way of maybe looking at things, thinking about things as well. And I hope my presentation will be able to give you a bit of perspective of my own experience back in Singapore. So one thing that may be a bit unusual about myself is that in the postgraduate medical school, we all actually come with a bachelor's degree prior to entering medical school, and my bachelor's was actually in architecture. So I had studied architecture in the National University of Singapore prior to entering medical school, and now I'm pursuing my MD and finishing up my final year, hopefully. But I think this is relevant, because the study that I did was something close to my heart. It was about linking both the potential and the power of the built environment, architecture, and about health and aging. So to bring us on, I just want to start with a little bit of background of Singapore. I'm sure most of us are all familiar as well. I've spoken to some in the audience who've just actually come back from Singapore. But Singapore is just this little island in Southeast Asia. We are very small, and actually, over the course of the conference, I had met some fellow conference participants who had asked me, how small exactly? So last night I went to Google and went to see, Google actually allows you to superimpose maps on each other nowadays, and actually superimposed Singapore onto Antwerp. So if you see the diagram right on the far right, that shadow is actually Singapore compared to the whole of Belgium, and we are barely even the size of perhaps Antwerp. But what's interesting to know is that Singapore's population is actually close to 6 million, and yet Belgium's population is close to 12 million. So if you think about it this way, we're actually extremely dense. We have half your population, but squeezed into a size, barely the size of Antwerp. And that poses its own different challenges as well in our environment compared to the environment here. But at the same time, it could be used to be potential areas of intervention, which would be the project. Yeah, and just a little bit more context about the challenges in Singapore that we face for healthcare is that one of the things is, as we all know, most developed societies face an aging population. So we are able to, the progression of healthcare and medical care is able to push longevity, right? We are pushing it to its limits. But at the same time, in Singapore, we see that there are rising chronic conditions such as hypertension, hyperlipidemia, and diabetes. And these are all, while we are pushing longevity, we are also pushing the chronic burden of care, because now people are living longer, but they're living longer with care needs, like chronic care needs, which need to be resolved. Yeah, and so one of the areas that I thought could be relevant to look at would be the built environment, because it's something we always interact with every single day, whether we like it or not. We actually live in a physical world. And this is one area that I feel, especially in my own local context, hasn't been tapped upon enough. There's great potential towards using it to change health or to improve health. And another thing about Singapore which makes it unique is actually 80% of our population lives in what we call a housing development flat. It's actually public housing. So public housing is really the public way of housing in Singapore, because 80% of the population lives in it. And the initial concept of public housing was actually standardized housing. It's universal housing. Regardless of your typology of your house, whether you live in a one-room house or whether you live in a five-room house, we all share the same corridor. And from the outset, from the door, the main entrance into the house, you actually can't tell the difference between the typology within the house. And I think while that allows for universalization of the design, it also allows for it's actually a really great potential point towards an intervention, because any intervention that you can use, you can retrofit quite easily, because now you have the same starting point, right? You have houses with the same starting board. Yeah, and retrofitting these interventions then can meet the masses, really the masses of 80% of the population. So back to the study proper. So this study was looking at the barriers and facilitators of the built environment, as I've mentioned earlier, the housing development flats and their neighborhoods, towards social participation, mental and physical health outcomes. So in a nutshell, health, and in particular, the eligibility criteria were seniors, because we wanted to look at perhaps vulnerable populations like seniors, especially at those with low income. So we chose those receiving less than 1,500 USD of monthly household income. So the method that was used in this qualitative study was actually a hybrid method. It combined a visual research methodology known as photo voice and a semi-structured interview. So it's rather small, but this was the initial concept mapping that I had together with my mentor, Dr. Lo Lian Ling. And what it used is that because it's a hybrid method, right, what we wanted to do is our initial input was analyzing the built environment, and our output was looking at health outcomes. But how do we get from one to the other? Because one is physical, it's tangible, and the other one we are looking at measuring certain, analyzing it. Yeah. So photo voice helped to anchor a physical aspect. For example, what photo voice was I went with these elderly participants, so I actually call them up, meet them on a certain day, we'll chat for a bit, and then they bring me for a walk. And they'll be given a camera. In this case, we actually gave them a Polaroid camera. And the elderly participants themselves were able to frame exactly what they wanted to take a photo of and take it themselves. So on one hand, it empowers them towards choosing a topic they wanted to speak about. On the other hand, it actually helped to anchor our subsequent semi-structured interview, and especially important with perhaps the geriatric population, because they tend to have a lot to say. And then when you have a photograph, they help to anchor and streamline it as well. So in itself, the research methodology was trying to capture something physical, and secondly, after the photo voice, we used a semi-structured interview to analyze it, to talk about it, what they feel about it, and hopefully from there, bring it from its physical all the way towards its health outcomes. So these are just some photographs of our walks together, taken by the elderly, and a mapping of what was done during the walks. And in the interest of time, I just drew 3 things out, and why I felt this photo voice methodology was actually very relevant. Because in the first photograph, we can see that this old elderly gentleman, he liked to walk around with his bicycle. He didn't actually ride it, but it was his walking stick, a very dangerous one, but he used it, and this was his preference. And I think that's the first point. Photo voice allowed me to experience their preferences, which I would otherwise not have understood if I didn't walk with them. The second thing was, it also allowed me to understand their limitations, because we see the second photograph, I was with a gentleman who was on a wheelchair, and although we have very fixed universal design rules in Singapore, for example, if you see the pathway on the background of this photograph, it had to be a certain width, but actually in his understanding, the pathway leading to the universal pathway was very narrow. He couldn't even access the universal pathway because of the narrow pathway leading to it. So I think their limitations were brought about during the method, and I could understand it. And lastly, I think photo voice allowed me to understand things that were time-specific as well, because we see that this gentleman was talking about how this shelter was so high. Yes, it did shelter, but in a time of rain, it didn't work at all because rain could just come in. Yeah. So there was a data analysis of it, and subsequently, these were the results that I plotted on this diagram. Basically, understanding that there are barriers and facilitators of every environment, but within this environment, there were certain things to this specific population that were more important than others. For example, their walkway design or their ramp design, and also certain things that were strengths for others, such as making design standardized, could also be weaknesses for others, such as, for example, just for one instance in this case, you could standardize housing to make sure that it's universal. There's no preference amongst who is perhaps richer or more affluent than others. But for the elderly population, then you have the problem of a lack of orientation. They're completely lost within a standardized uniform area. Yeah, and to just leave the last analysis, I think also in the interest of time, the final analysis is that I think if there's one thing I take away from this conference is that anything we think about is never two-dimensional. It's extremely multi-dimensional, and in this case, any facilitator or barrier is never just a facilitator or barrier. It comes in a sphere of what it influences as well. And if I could just leave you with these 2 photographs, I think this was taken on 2 separate walks with 2 individuals. And what we see was that this is the exact same staircase landing of 2 blocks. So one gentleman had the same staircase landing, and another lady had this staircase landing, but how they appropriated it was completely different. So it boiled down to their own attitude as well as their own interest as well. And I think this is the final slide. If there's ever anything, I think the built environment can really work like a chessboard. So a chessboard allows for, in an analogy, so we have people in a population who have different assets. Maybe we have kings, we have queens, we have, I'm not sure what the regular chess ones are. I don't play chess, but the regular ones. So we have people with different assets that already come into a neighborhood and a space. But how can we as health providers, as designers, actually design a chessboard where they can interact, they can move, and maybe perhaps because they are different assets, they have different moves. Some people can move more than others, some more limited. But the main thing is that we want the interaction, we want the movement. We want the movement not physically, that improves their physical health, but we also want interaction in their mental health and their social participation. Yeah, and with that, I've come to the end of my little sharing. Thank you so much for listening, and I do hope that I've shared something that could be relevant as well. Thank you.
Thank you very much for that. It's a fascinating topic. Are there any questions from the audience? We haven't had anything come in from the live chat at the moment. Thank you.
Thank you for a very innovative perspective from my point of view. Which were the challenges in your methodology, like in recruiting, in designing the content? I see that it's visual, but you also have verbatims and text. So just to deepen a little on the challenges.
Thank you for the question. Definitely there were challenges in this methodology. I think for one, initially just approaching an elderly participant with this concept seemed as though I was invading into what was a private area of their life, visiting their house, walking with them. I think there were initial barriers towards their openness to it. And subsequently, even during the walk, there were barriers in terms of its actual method, like the elderly holding the camera, the elderly being confident enough to take a photograph and be empowered to speak about it. And I think even bringing across the message to the elderly that they're able to speak freely about what was a barrier or facilitator for them. So I think in essence, the method, in terms of its openness by the participant, was a challenge. Yeah, I think that was definitely a challenge, but one that subsequently I feel a strength of this method is that in the method itself, it was kind of like therapeutic because the elderly themselves gained something from it. They felt heard and also they felt engaged in their community. Yeah, so I thought that while it being a limitation, could also become a strength. Yeah.
Well, thank you very much. Thank you, Alyssa.
Thank you.
We're now going to welcome Mark Harrington up, over from Ireland, to talk to us today about Healthy Aging Friendly Homes Programme. Thank you.
Thank you, Andrew. Good morning, everybody, and thank you for attending this morning's session. So I'm here this morning to talk about the Healthy Age Friendly Homes Programme, which is a programme in Ireland.
We had great difficulty climbing the stairs and going up and down, and with lack of vision, and it was dangerous. I tripped very easily on the stairs, hence the advantage of the chair. Unable to go out. I could go out with help, I suppose, but what's the point? You can't see. So if you're in a car, you're just driving in a cloud. So you just take it as it is. Stay at home. I cannot watch the television or anything like that. I cannot read or write anymore. And I'm dependent on other people all the time.
As a result of my rheumatoid arthritis, from the visit of the district nurse, I had to have my bed downstairs. She recommended that I have a commode, and she was very helpful. So I do miss the shower. So I'm hoping that I will be able to get the lift, and that maybe the bathroom will be sorted out. Like I used to feel a lot of the time that I was losing my, not my grip, but my self-worth, if you like, because I just couldn't do my basics.
I fell twice in the bath, having tried to have a shower, and I tore all my back, and I was black and blue. So I decided something has to be done.
There's only myself and Eddie in the house, and my arthritis was so bad, and Eddie got a bad back, helping me up and down the stairs. Things couldn't go on the way they were.
So we're here talking about older persons this morning, so I thought it would be key that we'd hear the voice of the older person. That is 4 participants of our programme, and they're just setting out the key challenges that they face within their own homes to stay healthy and remain at home for as long as possible. So I'm Mark Harrington. I'm the National Manager of the Healthy Age Friendly Homes Programme. The programme itself is a new way of working, so it's a collaboration between the Department of Health in Ireland and the Department of Housing and Local Government. So the programme is funded from Health in the Department of Health, and it's rolled out through local government. And it's rolled out through the Age Friendly Ireland Shared Service, which I would be working for, which is based in local government. So as we talk through this morning, you'll see our local support coordinators actually work within each of the local authorities. And again, a key ethos of Age Friendly Ireland is the voice of the older person in everything we do. So when we're doing a programme like this, it's crucial that we get the voice of the older person and what they actually want rather than what we think they want. So the programme itself is a support coordination programme. Its main aims are to enable older people to continue living in their own home or a home suited to their needs. It's to live with a sense of independence and autonomy, to be and feel part of their community, and to support the avoidance of early or premature admission into long-term residential care. So what I'm going to talk this morning about is the process of the programme itself for the participant and how the coordinator navigates that process. So from a referral point of view, maybe just to note that the programme itself is free of charge. There's no means test to it, so it's free. It's a free service for our older population in Ireland. Our referral pathways at the moment are the majority of them coming through self-referrals, family and friends, public health nurses, occupational therapists. We're strongly linked in with the integrated care teams within each of the areas, local authority staff, general practitioners, elected representatives in the local authority, and community groups would also be referring into our programme. So when we do receive a referral, what happens is our local coordinator would call out to the older person's home and carry out a needs assessment with the older person. A person-centred approach is taken, and we look at a couple of key domains, housing being one of them. So when we're talking about housing there, it'll be housing adaptations, works, maybe right-sizing if somebody wants to right-size or downsize into a house that suits their need, general maintenance, community and social. A lot of that would be befriending services, linking them in with community activities in their area, library services. So finances would be, with the cost of living, we would also be able to give people information in relation to what allowances they're entitled to, links in with social welfare, assist them with making applications. The majority of our health referrals would be into the public health nurses, primary care teams, occupational therapists. And then we also look at technology. Is there any technology assistive devices that we can use that will enable the older person to remain living at home? And then we also do a piece around energy and warmer homes, so we can help the person navigate that process to apply to have retrofits works done to insulate their homes. So what the coordinator will do is provide information, signpost to existing supports, facilitate the process by hand-holding. So we're all aware when we're making these kind of applications that they're not easy to navigate, particularly for older people who have no supports at all. So the coordinator will actually assist in making that application and lodging that application for the older person. They'll implement an individualised support action plan for the older person in consultation with the older person, but the coordinator will also track the progress. So we don't just signpost out to somebody, to an organisation or to health. We actually follow up to make sure that the older person is availing that service or that the service is being provided to the older person. But again, the voice of the older person, it's all about enabling and empowering the older person to make the decision themselves as to what they want to do once they have all that information. So we're not there to judge what the older person wants. We're there to provide the information and to help the person access what they want. We have some key partnerships, and just for time I won't go through in detail on it, but we're linked into Sustainable Energy Ireland, and we have 1.5 million annually, which will allow us to provide a full home energy assessment for the older person if that's what they want. It'll give them the full details of how to retrofit their house, what it will cost, what grants will be available to them. We're linked in with Tunstall Emergency Response to facilitate the provision of assistive technology devices. We also got additional funding at the end of last year from the Department of Health through Sláinte Care, which allows us to provide 320 participants with a telecare package, which is a fall detector monitoring device, wearable device. You can wear it anyway, it has GPS on it, and also an age-friendly tablet to help them connect back in digitally as well. And we've also developed a service mapping tool to assist us to provide a service to the older person. So we have the help points on that, community groups, social recreation and transport, which we're finding is an issue for older people, particularly in rural areas, to get to hospital appointments or the like. So again, we can help identify the process there. So I have a couple of case studies here, and you would have seen Peter at the start of the video initially. Peter is in his 80s, lives in Cork with his two siblings. They live in a house that's over 3 floors and is over 100 years old. So you will have seen that Peter is visually impaired. So after the needs assessment, the support actions that were put in place through the support coordinator was that a referral was done to the National Council for the Blind Ireland, and a text-to-read device which enables Peter to read the newspaper on his post was provided to Peter. A referral was made into the occupational therapist. So Peter was using the wooden stool as a shower seat, and now the occupational therapist has provided a shower chair, a combi frame, a seat for the toilet with support bars. He's availed of the housing grants, so successfully applied for and has had the work done. So we've upgraded the electrics there. All sockets have been raised to accessible levels, a new fuse board installed, rewiring of the heating system, external lighting, a new cooker switch was put in place. If you can believe it, that the kitchen was on the first floor, and Peter and his 3 siblings in their 80s had a gas cooker. So they had to carry the gas cylinder up to the first floor to make it work. So you can see that the implications from a health point of view and the risks involved in that. So a stair lift has now been put in place that spans the 3 floors, which allow the siblings to access the floors safely. An application for the fuel allowance and household benefits package was applied for and has been availed of. Availed of a free home energy assessment through the programme, and he's now qualified to have the retrofits works done for better installation and to create a warmer home for him and his siblings. A referral was made into Tunstall, and he has a Pebble device. It's a wearable device. Obviously, the watches wasn't for Peter because of his visual impairment, but it's a device, it's a fall detector and a device that he has connectivity to a 24-hour monitoring centre if needs be. And then the coordinator facilitated the move out of the house for a week to allow all the kind of works to be done. So the outcomes and outputs is a restoration of confidence for Peter. Falls prevention, so we all know the implications of fall prevention for Peter himself, but also on the health services. Re-engagement, we have now the health services going into the house, Meals on Wheels are going into the house, the public health nurse is going into the house. It's re-engaged, it's given Peter more confidence, the devices have given him more confidence, and again that all leads to the avoidance of long-term residential care. I have another case study there. I'm not going to go through it just because of time, but it's very similar. Just to say that Geraldine was referred in from the HSE primary care teams and availed of the same services and availed of the telecare package also. Just maybe the addition to that is that it's the self-worth and independence for Geraldine. It was the first time that Geraldine had been upstairs in her own home to her bedroom and her bathroom in over 2 years. So the health implications and mental health implications you can obviously all see there for Geraldine. So I started the presentation with the voice of the older person, so I'm just going to let the presentation finish with the voice of the older person. So again, it's the 4 participants just explaining their experience after going through the programme, and so I'll let the older people tell you their experience.
Now we're all the help now from Mary here and the grants. Makes life very, very comfortable and takes away all the danger, and I feel more relaxed. Oh, it's totally transformed my life now. Living at home, I stay at home for good now. There's no talk about going into care or anything like that. Even though lots of sight is there and it's difficult, I can stay at home now in my own home quite safely and comfortably, yeah.
Since I got the wet room done, it has been absolutely marvellous. I can have my shower, use my creams, and I can use the loo and feel like a normal person again. And that is absolutely wonderful. It's given me back my dignity. If I hadn't been referred to this programme, I don't know what I would have done or how I would have managed. So it has really enhanced my life. I can't thank the age-friendly people enough.
The more people that find out about this, the better. I feel there's people living in circumstances and they're afraid to tell their own families that they're not coping. And this way they can get themselves sorted and have a think about things and take their time.
It's a new lease of life for me, myself personally. It's the freedom of being able to leave my home and come back to my home. I wouldn't want to go anywhere else. I wouldn't go to a nursing home. Nothing wrong with nursing homes, but I prefer my own corner. It's my first home, and it will be my last home.
Thank you very much, Mark. It's great to see the outcomes as well of the, the hard work, the difference that you make into older people's lives. It's fantastic. Are there any questions from the floor? Again, there's been nothing coming in online. Got one back here.
Thank you. I'm from the Netherlands. We found in some research where we thought that often if we had people with a more practical or lower education level, that the more information we give, it makes them harder for them to decide. And here, obviously, you've got some people which you have to give them so much choices or not. How do you cope with that in this program?
Yeah, and when we started off the program, we kind of thought that we'd be going out visiting the older person one time and putting the supports in place. What we found out very quickly was that the person would deal with that one big ticket item first. So they might get referred in for the housing adaptation works, but it's only when you get to the second, maybe, and third visit that the confidence had been built with the local coordinators and the additional information. It's at that point that the person is confident enough to discuss maybe the other issues around it. So it's not that we would go out and let's say, here's all that information. It really is kind of the person's referred in usually for one area. We do as many visits as it takes to either build that confidence or to enable the person to make that decision themselves.
Can I add a question? I understood that that's the interdepartment program. So I understood there is kind of a IT communication platform where the all comprehensive plan is reflected and is accessible to the person. I don't know if the platform, the application the person was showing is something that is standardized for everyone, or is there a way through which all these actors communicate and integrate their plan?
No, at presently there's not. So at the moment, the program is moving from phase 1 into phase 2. So we had a pilot over 9 local authority areas. We were successful, and Adrian will be speaking to maybe the research part of it, and we're successfully rolling that out now over the next month to go to every local authority, at least one in every local authority. So it might be, as part of the second phase, the technology device that we're providing to the older person is more about digital connectivity. So there's kind of companion apps on it, very easy to use kind of events, and we're able to prompt the older person if there's an event in their area. It's more for that rather than that we would have all the kind of actors using it as a kind of a case management system. Thanks.
Well, thank you very much, Mark. That's brilliant.
Thank you.
I'm now going to invite Mark up to the stage over from Barcelona to talk to us about their coLLaboratory. Thank you. Thank you, Marco.
Thank you so much. I'm here to speak representing 10 institutions, so I'm the voice of an ecosystem. Just as a first question, who is familiar with the concept of a living lab? Raise hands, please. So I would say there are some, but it's not the majority, somehow. So this is our project of Living Lab, so I won't show specific results, but more journey, I would say. This is the way of moving, right? Okay. And of course, the reasons to start the Living Lab project for older persons or for aging is quite intuitive. I mean, you know that the impact of us becoming old is very big. And what we wanted to do, since there are a multiplication of services and technology that are being created for older people, we want them to be not only consumers, but producers and an active part of the system for the services and technology that they have to then use. And of course, there are more reasons, because in many cases, for example, this is a case of research, but for innovation, it could be the same. The priorities and where the money is put is not usually following what really people need and what they ask for. Here you can say that, for example, in research, the majority of the money go to the commercial trials and drugs, and not much money on what really other type of services, education, psychology, physical exercise, etc., that people value. And this is the idea of the Living Lab. The Living Lab we set in Barcelona, and we are start moving our first steps, is oriented to mainly one scope. So our value proposition is to become an open innovation platform. So we want to co-create services and technology with older people and their caregivers, okay? And we also want to offer an ecosystem to test new service and technology. So we can co-create and test in our own environment, or we can accept proposals from whatever, companies, research, and so on, and offer them the methodology and the test environment. Usually the Living Lab are fundamented on the concept of the four quadruple helix, so involving end users, but also research, administrations, and companies. In our case, there is 50 users because we want to be an integrated care living lab, so we have, of course, to involve healthcare professionals and social care professionals together with older adults, but also, of course, the dyad with the caregivers. And I think this next slide shows better which our proposed methods. So we want to go from macro to micro, or the reverse. So we want to work both on a level like macro level, community building, community of practice, so communities that are stable, from which we can detect needs, and with which we can work about, for example, developing strategies and operational plans, but also work on services, creation, and testing, so usually complex intervention for these older people and their caregivers, and products. And we think that products and services are the added value. I mean, if a company comes to us with a technology, we can propose how to embed this in a service delivery with older people, and this can add value to their, let's say, specific goal, and the opposite, the reverse, okay? We are 10 institutions, as I said, so we represent healthcare, specifically geriatric care and primary care, but also an umbrella of social care institutions, different universities, 3 local companies providing digital health, caregivers at home, and architecture services for better aging and health. And in particular, we have an association which represents old retired persons with which we started this journey. So we started sharing the idea with them, and they are part of the Living Lab from the very beginning. Of course, they don't represent the heterogeneity of older people, so we are now working to bring at the Living Lab other organizations representing other types of users. For example, we have the Catalan Stroke Organization that joined. We want to involve people with dementia, and also we just involved the local administration of the area of Barcelona. This is our iconic, I would say, space, Living Lab space. This was a donation by IKEA that was oriented, let's say, to redesign the house of the future for older people. Okay, so they started an initiative with the architects in Barcelona, and when they finished their journey, they donated to us this little house, which is like a big garden house or a small house, depends on how you see it. And that's a space where we can run, let's say, groups and participatory dynamics for older people. And this is attached to our geriatric hospitals, where we have also simulation spaces in the wards. Some idea of what we do in practice, right? So talking about some projects, so the micro level. This, for example, this is a project in which we converted the mechanic arm thanks to the participation of healthcare professionals, but also older people with disability. We are converting this mechanic arm to become a robot that interacts automatically with the person and help them to be fed, okay, supervised or not by staff, and also looking at security, dysphagia, and so on, just with the visual contact and also talking to people. This is an example. Or we are co-designing with end users an evaluation tool to detect like prompts and PREMs, so patient-reported outcomes that Aida who is here, presented a couple of days ago here at the conference. Or we are working now at how we can increase the adherence to vaccination, listening to what all older persons say, so which are the barriers and facilitators and new ideas about how to promote vaccination, for example, okay? Or, as I say, we are working at the house to age in place or walkable neighborhoods. As a meso, let's say, product, somehow, we are now managing a large project, demonstration project of integrated social and healthcare, healthcare, and we want to do this with older persons and their caregivers. We don't want to think a model from the expertise of professional or research. So this is something that, of course, is probably straightforward in this type of conference, but the Living Lab is also instrumental to this kind of integrated care projects. And finally, as I said, we want to build a community of practice locally in the city of Barcelona. We are in the very center of Barcelona, but also outside of Barcelona to represent both the urban environment and rural environment. And so we are running different, let's say, happenings to detect needs of older person and to work on what we can do to overcome these, let's say, barriers to healthy aging. And also we had a presentation yesterday in the plenary poster session about some results of this specific project. So we think we are in line with recent commitments and line of the WHO and United Nations about the decade of healthy aging, because we want to promote age-friendly environments, we want to combat ageism, we want to integrate care and work towards a better long-term care in place, and of course we want to connect stakeholders and give voice and engagement to older people. So I have been listening to other presentations mentioning living labs of different types, more oriented to research, practice, and so on. I think it would be very nice if at some point in this conference we could share ideas and do benchmarking about the living lab. So thank you so much. It's done.
Thank you very much for that, Marco. There's a real interesting theme around architecture, I think, coming across with ageing and how it changes. Are there any questions for Marco from the session? There's nothing from the online at the moment.
Thank you, Marco, for the presentation. And I understand that you detect innovations. And how do you detect challenges or these innovative technologies, programs?
So our idea is more than detecting innovation, to detect challenges with older persons and their caregivers. So what we want to do once we detect challenges and we are more known at the local level to match, let's say, challenges with possible technology that we can scout to see if this help, let's say, to overcome these challenges. I'm convinced that technology itself, by itself and alone, is not the solution, but of course it can help within, let's say, a more systemic approach. So this is the idea. There was
one.
Hi there. I really appreciate what you're doing, and I don't want to pick on you because it's such a collegial conference. But I'm from North America, and Europeans really seem to understand food culture and that food is so much more than an instrument. So I was very surprised by the robotic arm. And I'm wondering if you could talk me through the humanity and ethics and any pushback on that particular innovation.
You raise a very tricky point, because there is, even inside the Living Lab, so even inside the 10 institution funding the Living Lab, there is a lot of, let's say, controversy about the feeding arm or robot. So, for example, at the very beginning, the Association of Older Persons were kind of skeptical about, because they say, I don't want the robots feeding me, I want my relative or somebody human, some human with human touch feeding me. And so we engaged in a series of discussion about that, and we came across a very, I think, graphical synthesis. So so comparing two pictures somehow, no? In the first picture, you have the family member, the daughter or the son, feeding the older person at home, okay? And in the second picture, we have the robotic arm feeding the old person while the daughter or the son eat at the same moment. So we go back to a social happening, which is something very traditional in our culture. So it really depends on the way you look at it, okay? Sometimes, is it better to have a robotic arm feeding you, or like neutral personnel that is busy with 20 tasks and it's not really giving the right attention to the person? I think we need technology, but of course we need also to individualize it and to tailor it based on individual preferences. So someone might prefer to have the daughter or the son feeding them, even if it's less social somehow, and somebody else might get used to the robot, which can be also, I don't know, entertaining the person or doing different tasks while eating together, for example. But that's, of course, we need a lot of ethical reflection about that.
Well, Marco, it's got time for one more, yeah?
That's a slow warm-up, but...
Hi, very amenable that you have the coLLaboratory that's really focused on aging. Just my question around engagement, particularly, what are the challenges that you have with actually bringing people and being open with engaging with them and using different kinds of technologies?
I think that's a very important question, and here there is some person like Luvi, for example, who is in charge of the engagement part, and he could speak much better than I can do. He's more expert, and I see that you really need to devote a lot of time and build a sense of, coherence, cohesion, trust. And he is, for example, in this series of the appetizers, in which we try to build a community of practice, he spent a lot of time not only going straight to the point and extracting from these people their voices, but creating this sense of trust, relationships, like a flexible and relaxed environment. And I think something which is also very important is how do we reward them? Because the usual approach we have in healthcare in this sense is like asking people things, but we don't give back anything. And what we are committed to do is like to give back the results of what we do, and also give them the possibility to test the solution they were involved in co-creating. So this is, I think, the least or the minimal feedback we can give them. Of course, we can go more, right? We can even pay them or whatever. But I think we really need a strategy to protect, guarantee safety, and reward these people if we want to engage them and spend a lot of time to do this. This is a fundamental value for us.
Well, thank you very much, Marco, from everyone here. I'm going to invite Adrian now over from Ireland to talk about the evaluation on the Healthy Aging Homes programme that Mark had already presented. Thank you very much.
Thanks very much, Andrew. Thanks a million, everyone, for coming along today, and to our lovely conference organisers. It's been a wonderful couple of days. We're delighted to be here. My name is Dr. Adrienne McCann. I'm the Principal Investigator on the Healthy Age Friendly Homes programme that my colleague Mark discussed just 2 presentations ago. Before I start, if anyone is into social media, my own Twitter handle is there. Very boring, but Age Friendly Ireland's Twitter, they put out lots of supports, news items for older people, and a weekly newsletter. If anyone is interested, feel free to give them a follow. I'm going to start off a little bit around, I suppose, what the rationale behind the Healthy Age Friendly Homes programme, and I know Mark has got into this a little bit, but what have older people told us about what their preferences for care are? And what we know is that older people, they want to remain living at home for as long as they can. They want to remain independent for as long as they can. They need supports to do that. I've used the word burden here. This is the word that older people have used with us. But they see themselves as they age, that they are a burden to their family, and they don't want that. They want to be able to look after themselves. When it comes towards more sort of end-of-life care, very few people will tell you, if you ask somebody, where would you like to die? There's very few people that would say, I want to die in a hospital. People want to die at home, they want to be in familiar surroundings, and they want to be around family and friends. So really the overarching aim of this programme is to support older people to age in place for as long as they can. So just a bit around the collaborative approach. So we've multifactorial stakeholders involved in this. We have Age Friendly Ireland, who are part of local government, and they are leading the rollout and in the employment of the local coordinators. Sláinte Care, they are part of our Department of Health, and it's around the reform of our new health service. And then Maynooth University, which is myself, and we're the academic partners on this, evaluating it. So our 4 kind of key objectives there as well, enabling older people to continue living on their own, in their own home, with a sense of independence, to be engaged with their own community, and hopefully avoid instances of unplanned care or admissions to long-term care as well. So a little bit around our evaluation. So we took a mixed methodology approach to the evaluation. We have our 5 standardised outcome tools that we used in this. We also have an additional 6th outcome tool. It's not on this, but it was an adapted tool we used ourselves, looking at activities of daily living and IADLs as well. So really what we were looking to measure was around health status. So many of you are familiar with the EQ5DDL. We looked at social support, we looked at quality of life, loneliness, and self-efficacy as well. In addition to this, we also undertook qualitative interviews with a subgroup of our participants, and we used the RE-AIM framework to try to capture data there relating to the reach of the programme. So are we reaching the right people? The people who are involved in this programme, are they the ones who are going to benefit most from it? And if not, how do we reach those people? Effectiveness, do participants find the programme beneficial? Is it useful? Do people actually want to be involved in it? Adoption, given that we're over 9 pilot sites, each local authority will have different structures as well. What are the kind of key items that we need in each local authority to ensure that there's uptake there? Implementation, so although we use a set protocol and the programme's implemented the same way across local authorities, there will be slight variances in terms of how local coordinators work, what they find works best for them, based on the needs of the older people as well. And then I suppose looking towards the future, maintaining it and scale up, what resources do we need to ensure that we can carry this forward? How can we maintain it, and how can we ensure the sustainability of the programme going forward as well? So very briefly, Mark probably covered most of this anyway, but again, just to reiterate, we had 9 pilot sites hosted out of 9 local authorities. The local coordinators themselves primarily were based in the housing department within local authorities. For anyone not familiar with the local authority term, generally it's your kind of municipal areas, your county councils equivalent. So each of the local coordinators would have undertaken a home visit out to the older person. Anyone could refer into it. You could self-refer it, you could refer a neighbour in. And at Anthem, we actually found that's how we were reaching those people who maybe weren't engaged in services. So maybe somebody who'd taken part in the programme and knew of a neighbour who, say, had no family or no friends, thought they might have been vulnerable, maybe not involved in services, and they could refer them in as well. So by that kind of snowballing effect, we're able to build the recruitment going forward as well. So the actual research evaluation itself, we used a subgroup of the participants in the programme. So, Mark, you can correct me if I'm wrong, we had about 2,000 overall in the programme. In order to take part in the programme, you didn't have to agree to take part in the research evaluation. You could still avail of the programme, but anyone that was willing to share their views and their thoughts and to work with us, we had recruited those in. So the data that I'm presenting today relates to 165 participants. Majority of those were female. Mean age was around 76 years, but we did have people as young as 54 years up to 96 years as well. Majority were living in urban areas. We did have quite a few rural areas as well, and even those who were rural were very rural, so it's great to be able to incorporate them in as well. A majority of participants were married as well. So some of our baseline results. So I'm conscious there's a lot on this slide, but really this is just a description in terms of what was the status of our participants at entry into the study. So we did a time 1 and a time 2 follow-up. So on entry into the programme, we did a baseline overview in terms of what their health status was, quality of life, loneliness, social supports, and then we followed that up 6 months later as well. So I suppose some of the take-homes within this, the health status of our participants, we generally had quite a strong level of health within the group. Self-reported health as well. I think participants indicated around 66.8% satisfaction there, and that was around on the visual analog scale as well. They did have low levels of social support, and again, we were collecting this data as we were coming out of COVID, so a lot of older people were isolating at home, maybe weren't as engaged with services as well. So some of our time 2 results, we saw an increase in 5 of the 6 outcome measures going forward. There were 2 at the end, which I'll go through as well, but generally speaking around quality of life, loneliness and social isolation, we saw some great improvements. I suppose of note, even in the self-efficacy, which relates to how older people cope with, I suppose, unplanned circumstances, so how they might cope with distress in their lives or how they might cope with an unplanned situation. We saw a 15% increase in the number of participants with the higher levels of self-efficacy. So that was people who said, I can manage okay, I have good coping skills as well. Again, at time 2 in our social supports as well, we saw overall a 9% increase in those that reported strong levels of social support. So within the group analysis there, we had a lot moving towards that. So over half of the participants at time 2 had said that they had strong social supports. The 2 here in red, these are the 2 that we saw minimal decreases in as well. So you might remember I mentioned there that we had a very good level of health at the start. It did decrease slightly, I think we had 0.2 points as well. But again, we're going to do kind of more within group analysis there as well to see is there any sort of trends within that as well. Functional ability, that relates to, we ask questions around can you, manage getting your socks and shoes on? We also looked at tasks around the home, like sweeping the floor, bit of hoovering, things like that, and we saw a slight decrease in that as well. But I suppose one aspect within it as well, we collected this data in the middle of winter, and we only finished there probably February, March time, so that had been going through from about August, and we do find that participants' mood was a lot lower, even as we were kind of coming towards the end. We think, God, great, brighter evenings, we can get out and about. So to a certain degree, you do wonder, if you don't use it, do you lose it over those quieter months? So again, we've a bit more analysis to do on that as well. So I'm just conscious of the time, but I suppose a few little snippets from our qualitative data. Grant. So this is some of our qualitative data from our participants as well. And you might remember going back to the RE-AIM framework at the start. So we're using that framework as well with our participants as well as our coordinators on the ground, and we're working to kind of triangulate that data. So things like the reach, asking people, how did you hear about the programme? Was it through a group? Are you already engaged in groups? But then with our local coordinators as well, how did they find people, or what did they find the most successful kind of recruitment techniques? The kind of 2 middle columns, if that makes sense, the blue and the purple one there, related technology. So just some of the kind of the snippets there that you get. Mark mentioned the Pan watch. And I suppose that technology, for a long time, when people made technology, it was always made for younger people. Technology wasn't designed for older people, whereas now you see the turn coming now and how you can take that technology. In some instances, like on the watch there, you can actually set like a perimeter for older people. So if you maybe have perhaps maybe a vulnerable relative and you're worried about them, and maybe you're in work during the day, but you just want to make sure that they won't go too far, you can kind of set a perimeter on it that, if they have gone further than, say, like the local shops, you'll get like an alert on your phone. Now, it's not going to set off any alarms or anything like that, but it's just so that it's just a little alert to know, right, they're on the move. Again, like the fall detector as well, anyone who's living on their own, maybe, nobody checking in on them too regularly, having the kind of, that sort of safe sense of security, that knowing that someone will be checking in on them if anything was to happen to them as well. Our local coordinators, credit to Mark, they were absolutely fantastic. probably the most beneficial part of the study was finding those people, and I think the participants themselves, they just said they're the nicest people, they're so supportive. You know, even for participants that felt, do you know what, I don't really need any supports now at the moment, but at least I know who to go to down the line if things change. So we can keep those people sort of still engaged. You know, we can still keep them on kind of the likes of the mailing list for social events, for social supports, things like that. You know, we're not they don't just drop off if they say, do you know, I'm okay at the moment. So there was some really nice sort of feedback coming out from that as well. So some acknowledgements before I finish, because I will run out of time, to our funders Launchcare, my research team in Maynooth, Tom there, to Mark and Emer in Age Friendly Ireland, and also to our local coordinators there as well. In terms of the next steps, from a data perspective, we're just working on the work order data to link that, so the likes of the types of supports that maybe somebody got, if it was maybe like the wet room or the bathroom and things like that, and linking that data back to our functional abilities questionnaires to see was there any links between people who are getting these sort of home renovations or accessibility features, whether it might have been a handrail at the front door, the back door, steps, things like that. So we're going to look to link some of that data. Phase 2 as well will be looking more towards sort of cost effectiveness in terms of kind of more of an economic evaluation going forward and a full-scale analysis. And then also delighted to say that Mark received full funding for a national rollout starting in the next probably month or two. So very busy time going forward. So, but thank you very much. I'm happy to take any questions.
Thanks very much for that evaluation summary, and the news that you've got national funding is incredible, so congratulations on that. We probably don't have time for a question. Has anyone got anything burning? Mark?
Thank you, great presentation. Quickly, one thing is about the evaluation. So do you think that the results that you, let's say, in which you found less impact will change if you look at a longer perspective or longer follow-up? And I was also curious about the background of the coordinators, so the people that really go and coordinate all the situation. So do they have a specific background? Do they have a specific workforce capacity? Or?
Yeah, so I suppose to answer your first question, like personally, I'd love to see that data collection over summer when we've better weather. Like Ireland's weather is not great. We've had a very tough winter. There's been snow, very bad flooding, things like that. Again, over a longer time period, yeah. I mean, some of the home renovation grants and things like that, they could be months in the pipeline before. So, you know, we might have been following up with people and they're still waiting on the works to be done as well. So you're not really getting a real feel for it. But again, if you push out an evaluation much longer than that, you're kind of talking, can people recall what the process was or what they went through? So yeah, to a certain degree, absolutely. In terms of the backgrounds of the local coordinators, there's an incredible mix of people who've worked in the housing departments. There's nurses. Who else is there? There's like a really mixed. Some are healthcare clinicians. But generally, all of those people have all worked with people before. There was no criteria. They didn't have to be a qualified OT or physio or anything like that. So that's great.
That's great. Thank you very much.
Thank you.
Now I'm going to welcome Katrine up onto the stage, who's going to bring it back to Belgium to close out our session.
So, good morning, everybody. My name is Katrine, and I'm coordinating the Long Live the Elderly program in Belgium. And thank you for the opportunity to tell you something about the program. Thanks to Adrian, who reminded us the preferences of care. So I don't have to go into them. But they're definitely part of why we are starting up the program. It's well known that social isolation is an important risk factor for the elderly. Mortality increases by 30% in cases of social isolation or loneliness. And there are about 19 million other adults in Europe, the main users of health and social services, and in many cases they access health services too late when prevention is no longer possible and treatment is long, expensive, and with limited effectiveness. The Long Live the Elderly program was developed to respond to this challenge. It's based on regular phone calls, home visits, and individualized care plans for the frail. The program also creates networks to increase social relations and reduce loneliness among the elderly. The methodology has been developed in Italy in 2004 by the community of Sant'Egidio and has since been implemented in Rome and other cities in Italy. In Belgium, the program was launched in October 21 as an initiative of the Antwerp Sant'Egidio community in collaboration with the city authorities and supported by the Flemish government care department as a caring neighborhood. Let us have a look to the different elements of the definition. It's a community-based care model. About 2 decades ago, you might have heard about it in other conferences, Flemish government policies on elderly care started to underline the importance of community involving care models. At the same time, we have to say that Belgium is among the countries with the highest percentage in Europe of people aged over 80 living in long-term care facilities. So we still have a healthcare system, long-term care system, that's very focused on residential care. Research, however, shows that the most older Belgians prefer to live in their own house or their own environment as long as possible. So we launched the program to support community-dwelling elderly. It's not only the growing number of elderly that requests a radical change in our approach to prevention and care, but also, as you see, the gap between the existing systems and the desires, the wishes of the older adults. The program is strongly committed to community building, to combat loneliness and social isolation, involving neighbors, volunteers, and all existing facilities and organizations in the target area. To create caring neighborhoods, the most important partners are the other adults themselves. Not only the beneficiaries of the program, they're the first people, first of all, to help to build in their own environment the program by creating informal networks to support their more vulnerable peers. We're using a proactive strategy. European studies have found that community-dwelling elderly in Belgium face multiple barriers to home care, and accessibility is one of them. The lack of someone able to interact with the care system, for example, is a big problem. In the first year of implementing the program in Antwerp, we actually came across many cases in which other adults simply didn't manage to contact health care service by themselves for reasons of digitalization, long waiting times at the telephone. Every day there are fewer offices where you can go to and talk to someone in person. We've really seen a lot of examples of these problems. So therefore, an outreaching strategy is very important. We are taking the initiative to contact the elderly, and it's a universal approach. We actively contact all people over 80 in the target area. So at the end, also, the most vulnerable and isolated are reached. This is also important when we talk about prevention. I'll come back to this later. An essential condition for implementing the program, as you can imagine, is cooperation with a local government to access to personal data. Here, the program works in cooperation with the city authorities of Antwerp. It's a monitoring program. based on telephone calls and home visits. An assessment of the biopsychosocial frailty of the elderly person forms the basis of the phone monitoring frequency. And that frequency can vary between anything from a weekly call or even more if necessary, but it can also be a call or a visit every 6 months. And of course, there's also the possibility that an elderly person or somebody of their caregivers or in their environment take the initiative to contact our service. In cooperation with existing social and health care actors, individualized care plans are developed where required. And they can include various interventions, going from advice on how to reorganize homes to prevent falls, to organizing care pathways, or proposals to be included in socialization activities. All program activities are fully supported by a dedicated software, and this software provides the daily tasks to each community worker, and makes their input available for controls and fine-tuning the monitoring and the individualized care plans. In Antwerp, the actual monitoring of the elderly started in March 22. In 2 city districts, Merksem and Hoboken for the locals among us. And by the end of April 23, with a team of 6 part-time community workers and 2 part-time local coordinators, we had registered over 2,000 elderly who want to participate in the program. And that was a result of over 14,500 phone calls and more than 4,000 home visits. So I would also like to underline some of our focal points. Very important is the aspect of prevention in the program. It's actually the main goal of the program, as we actively contact all the elderly in the target area. As I already said, sooner or later we also find the most vulnerable and the most isolated ones. Sometimes they do not succeed in contacting the services by themselves, but sometimes they also avoid to get known by the services for different reasons. Can be bad experience. We met situations in which people were very happy to live the way they lived, but the environment had its doubts. Can be reluctance to accept help. Can be fear of being forced to move to a nursing home. And I can tell you, in our society, the pressure to do this is huge. Mm-hmm. And of course, we also get to know a lot of older adults who are not in need of extra support because they're in good health conditions or well surrounded by strong networks. I already referred to them as the best, as the caring neighbors, the best people to build the program in their own environment. But whatever the situation is of the older person we contact, the tool we use is always the same. Build a relationship and gain trust. If social isolation is a risk factor, social contact is a means of prevention. In this way of working, the older person, the community worker, is well known to the elderly and can also provide targeted assistance when a crisis occurs. There's already a relationship of trust. The program is much appreciated by the elderly population and the other participants, such as neighbors, family members, because it's a very light, not intrusive intervention. We make sure people get to know us, and when they need us, we're there. I would like to say something about sensibilization. It's not easy to grow old in a society in which, I have to watch my time, thank you, Mahinder, in which producing and consuming seems to be the only ways to make a useful contribution to society. Still, there's no doubt that many older people could continue to use their skills, their knowledge, all the experience they achieved during their long life until old age, if only they were given the opportunity to do so. Participating in the program gives them the opportunity. We really have a proposal for everybody. Also to the most frail among them. But a friendly visit, having time for each other, and so many other things old people have to offer are not valued in our society, and so older people feel redundant. We invest a lot of time and energy in explaining that nobody is ever redundant. We have to explain this to society and to the elderly themselves. And also this is a way of prevention. So regardless of individual vulnerability, participating in the Long Live the Elderly program restores dignity, meaning and sense of belonging to an often marginalized and underestimated population group. In fact, a society that does not recognize the value of the contribution of the elderly is a poor society. So by participating in the program, and that's the last point there, people can live old age not only in an active and healthy way, but also in a way that restores sense and meaning to their life. So not only healthy and active, but also meaningful aging. I will show you the last slide about the outcome, but maybe I leave it to you to read it. I don't know, I still have 1 minute? Okay, then I'll go on. So the methodology has been used in Italy for 20 years and has proven to be effective. It's too soon to give a lot of results in Belgium, but of course we started the program based on the very positive results in mostly in Rome, timely detection of care needs, improved referral to professional care, and very important, less unnecessary hospital admissions, less unwanted nursing home admissions. I could add to this that we're also thinking very much and also realizing alternative forms of living together. In Rome, for example, in the past 20 years, about 60 new co-housings came out of the program. People, 2-3 people living together, helping out one another. So, and of course, through networking with professional services, the program also addresses the challenge of integrating social care and healthcare. In the long term, Long Live the Elderly aims not only to improve the quality of life of elderly people and communities, but also to advise policies for necessary changes in elderly care. Thank you very much for your attention.
So I think we've got some time for questions. Does anybody? Mark. Oh, we've lost the microphone. Marco? Do you mind?
Hello, thank you for the presentation. I live very close, so I know Hoboken and Merksem. But I wonder, because the context is, it's a city, is there any experience, maybe in Italy, because they do it already there for, or they're experiencing about 20 years, or maybe here, for, let's say, in a rural situation, because of course we have frail patients or people there with the same problems, but they are living in another setting, not that close as it is in a city or in a environment as Hoboken or Merksem. Are there any experiences? Well, is it reproducible in, let's say, on the countryside, where people live with the same problems?
It hasn't been tried out by now, but I'm sure it would be worth trying, because the methodology is also is so simple. We are also prepared to help people if they say we want to implement the program. We can give formation, we can provide you with the tools to do it, but it would actually be interesting to try to implement it in a rural context. I can tell you something we heard in Merksem recently, somebody explained this, you have Merksem village and Merksem city. So also, which means in the same context, it's much more about connection, and it can be, it's not always the contradiction between a village and a city. It's about connection, about bringing people together, and well, that's what we're doing with the program. Mm-hmm.
Thank you for your presentation. I was wondering, when I hear you talking about meaningful life and belonging and things like that, and I look at the last slide of the outcomes, then I actually miss those outcomes. And it seems like we're almost stuck, how we evaluate programs like this on costs and things like that. But outcomes like belonging and experiencing more meaningful life, are those outcomes that you actually look at?
Yes, sure. I should apologize for my rather concise PowerPoint maybe, but for us those outcomes are really important, and that's what people tell us. You know, they tell us we're so happy to know the program already, because now I can still be active in so many organizations, but one day I will not be have this possibility anymore, and then I already can, I already know you. We have people who are in a wheelchair, living at home, not able to go out. They weekly make a series of phone calls to other elderly people to combat loneliness, to make new connections. I think it's also very important to make those connections in between generations. I think a difficult thing of a residential setting is that elderly are always, among other elderly, they should see young people to help them to believe and to look at the future. And this definitely is an important outcome of the program. Give back the hope and make people dream again.
Well, Katrin, oh, we've got one more.
And in line with your comment, how do you measure all these complex terms like being meaningful?
Well, of course, things like like loneliness and being meaningful are very difficult to measure. So by now, actually, we are measuring things like, do we manage to increase the informal network? This is something we can manage, and then you know you have given people more connections. And we know that one of the forms of loneliness is, the country of loneliness is having meaningful relationships. So this is something we can realize, and this is also something we can count. The things we count is how many hospital admissions in a short period. These are alarm signs that somebody is not well surrounded, or and then of course we collect the stories of people who tell us that already the program has changed their lives. Neighbors who get in contact with one another, they're living about 200-300 meters from one another, and they never met, and now they're looking after one another. So I could give some more examples, but maybe, yeah.
No, that's really good. We actually had a question come in from Mark from online, and I think you've got the microphone. No? So Mark, a question that came in for you was, were there any challenges in service integration before you launched your program?
Sorry, Andrew, could you repeat that, sorry?
Were there any challenges in service integration before you launched your program?
Again, I suppose when we looked at the program, there was a couple of smaller pilot programs similar to that we rolled out, but they were probably coming from more of a clinical setting. So the referrals were about maybe getting the person who had reached that crisis point and working the supports in around them at that point. So what we found was we wanted to develop it so that it'd be more wide-reaching. So we didn't really have any issues in relation to that when we were rolling out initially, but we kind of looked at the models that were done before and seeing could we expand on them within the community.
That's great, thanks Mark, and hopefully that answers Gary B's question, which came from online, I think. But if there are no more questions, I'd just like to wrap the session up and thank all the speakers, all of you for attending here, and everyone who's come from online. I think it's interesting to hear from 4 different countries, and you've all got a lot of shared experience and a lot of commonality across the globe. So it looks like people are people everywhere, where they live. So thank you very much for everybody.